basically, the reason we are starting out with the most complex disease in congenital heart disease is I think that's going to be something that you'll find a little challenging understanding if you haven't had very much exposure to it. How do I advance my slides? It's here. Next week, we're sort of doing this a little backwards. I'm starting out with a complex problem, and then next week we'll do more general congenital heart disease and cover a lot of different diagnoses and go through some anatomy and stuff to kind of help you get started understanding some of the anatomy if you haven't been exposed to this before. So I'll talk to you a little bit about the adult congenital heart disease population. These numbers are growing. Secondly, we'll talk about various common single ventricle diagnoses that lead to Fontan repair. And then we'll talk about long-term clinical issues that we all will be seeing in the Fontan patient, and then what transition means and what the issues are in terms of transitioning patients to taking care of themselves and then transferring their care from Children's Hospital or wherever they were cared for to the University of Washington Adult Congenital Heart Disease Program. And if I didn't introduce myself in the beginning, I'm Lib Slaughter. I'm the nurse practitioner with the Adult Congenital Heart Disease Clinic here at the University of Washington. 85% of children born with congenital heart disease will survive until adulthood, and this is a growing number of adult patients because repairs have improved over the years and adults are living longer, basically. In the pediatric population, though, it's not necessarily a growing number. There's a kind of set number of kids born with congenital heart disease, and that's a stable number. The burgeoning adult population is because of our good medical care and the new treatments and surgeries that have been developed over the years. Estimated 1 million, that's probably a little higher number now in the United States, and it's growing 5% annually, roughly. This is just a diagram that sort of shows you kind of the percent peds patients in 1965, and only 30% were adults because basically they weren't living it long enough to make it into adulthood. Fast forward to 2005, and you can see there are more adult congenital heart patients in our country now than there are pediatric patients with congenital heart disease. So what is the Fontan repair? It's the third repair typically in a series for hypoplastic right heart syndrome or hypoplastic left heart syndrome and the hypoplastic left heart variants. The first surgery typically is a Norwood, or they may have had a pulmonary artery band. The second is generally a bidirectional Glenn. Some of them will have a Damas K. Stanzel repair as well, and I realize I'm talking about repairs that you might not be familiar with, but we'll have some diagrams later. The third surgery is the Fontan repair, and the Fontan surgery was first performed in 1971, so that gives you an idea of how relatively new that surgery is. And so prior to 1971, a lot of these patients were dying early, sometimes, as a neonate. So they weren't surviving. And the ones done in 1971 were typically done for right hypoplastic problems. These are some of sort of the types of Fontan's repair, starting with the oldest type of repair, which is the atriopulmonary Fontan. The next improvement in that repair was lateral tunnel repair, and then finally the extracardiac Fontan repairs. The atriopulmonary Fontan, as you can see on the left, is a connection between the right atrium and the pulmonary artery, and we'll discuss why that was needed, but basically to get flow from, direct the venous flow into the pulmonary artery so it can pick up oxygen and so on. The lateral tunnel was developed because the atriopulmonary Fontan, what happens over time is that right atrium gets huge, the right side gets enormous, they develop arrhythmias, and they fail. And basically this type of physiology is dependent on passive flow from the right side, meaning the right ventricle is not a pump here. It's just flowing from all the IVC blood is flowing by passive flow up into the pulmonary arteries with this type of repair. And so the lateral tunnel then sort of fixed that problem of the right side getting big, but in order to allow sort of a pop-off for pulmonary pressures, they sometimes left a hole between the right atrium and that lateral tunnel channel that's called a fenestration. In case you run across that in the literature in the future, you'll think I've heard of that before. And then the last improvement in this repair was the extracardiac Fontan repair, which actually connected the IVC blood all the way up to the pulmonary artery and entirely bypasses the right atrium. And then you really cut out a fair number of those arrhythmia and expanding right side type problems theoretically.
Sorry, can you back up for just a second?
Yes.
How is the third one different than the second one, except for the right atrium is more detached?
Exactly. It's more
Okay.
detached. There's not an enormous difference. They tend to have maybe a little bit better cardiac output in the extracardiac Fontan, and for reasons that I'm not clear on. And actually, to be honest, the extracardiac repairs are now just 20-year-olds or something, and so we're just seeing those, so we don't really know what the long-term outcomes are going to be. So they thought this was an improvement over the lateral tunnel, and we're trying to see what those improvements are. But your question is a good one. And we don't really know how long, if the extracardiac Fontans will do better than the rest of them. The thinking at the time is that they would. So I'm just going to go through some of the initial repairs. We're not going to spend a lot of time on this because I think this is sort of hard to remember unless you're dealing with it on a daily basis. But the Norwood repair is essentially trying to get blood flow going into the aorta, and then through a shunt, blood flow gets to the pulmonary arteries. And this repair is only done in neonates. As they grow, they outgrow their shunt there, which is providing the blood flow to the pulmonary arteries. They need a different repair to increase the flow. This is one type of repair where they combine the pulmonary artery with the aorta, and they do a Glenn repair, which then puts the SVC blood directly into the pulmonary artery. And then this is another diagram, which I think at quick glance, it's very hard to understand these diagrams, so don't beat yourself if you're looking at these and you don't get this quickly. This information comes very slowly and over time. So I'm not going to spend time, in order to get to some other material, but to have some familiarity with these repair names and know where to find the diagrams so you can look at them a little more carefully. Here are some of the diagnoses that led to the early Fontan repairs: tricuspid atresia, double inlet left ventricle, pulmonary artery with intact ventricular septum, and recognize that maybe some of you have never even seen these diagnoses before. We will go into the diagrams quickly. So on the left is the normal heart, on the right is tricuspid atresia, which basically is a right-sided single ventricle lesion in which the tricuspid valve didn't form very well, therefore no flow was going into a right ventricle, and therefore the right ventricle didn't really develop. So you end up with hypoplastic right heart syndrome, which is essentially what this is. And many of our sort of 30 and 40-year-old Fontans, this is a pretty common diagnosis that you'll see as an original diagnosis, even though there might be billed as a Fontan repair. It is good to know what was their original diagnosis, because it helps you to understand where the lesion is. So this is always a right-sided lesion. Double inlet left ventricle, more complicated to look at. You can see that the LV is actually on the right side, so the ventricles are inverted, and the the right ventricle, which is on the left side, is not very well formed. So this ends up being a hypoplastic right heart type of lesion. Even though it says double in the left ventricle, it doesn't lead you to think it's a right heart lesion, but it kind of is, because the big ventricle you see is a morphologic left ventricle. And when I say morphologic left ventricle, I mean the left ventricle is smooth walled, the right ventricle typically has these trabeculae that little channels and things that you see if you were to look at it on echo, and that's one of the ways you can tell the difference between an RV and an LV. To hit on some other diagnoses that led to the more recent Fontan type repairs, like extracardiac repairs, hypoplastic left heart syndrome, the variant of the hypoplastic left heart, and unbalanced AV canal. Many of you have heard of AV canal defect as endocardial cushion defect, or more newer term is atrioventricular septal defect. You'll still see a lot of AV canal defect. Many of those canal patients, as you may know, we see in the Downs population, but those aren't unbalanced AV canals. Those are regular AV canals that have two well-formed ventricles. They end up on the single ventricle pathway for repair if one ventricle is not very well formed. And so that's sort of a variant of hypoplastic left or right heart, depending. This is a picture of hypoplastic left heart syndrome with, you can see the left ventricle is just not there, the left-sided structures are poorly formed, and therefore most of the blood flow is getting through to an aorta through the patent ductus arteriosus when they're born. And so efforts are made to keep that PDA open until they can undergo repair. This is a standard AV canal defect. You can see it has two well-formed ventricles. And this would be an example of an unbalanced AV canal. There's a large single ventricle, and in this case, a pulmonic stenosis, and dextrocardia, referring to the apex pointing to the right. Quickly, just to make a comment about survival and Fontan repairs, you know, they do tend to get sicker as they get older, and that varies depending on age. You can see the extracardiac data sort of stops. In this is maybe an older slide. It stops in age 10 there, but we do have some 20-year-olds that we're now starting to see with an extracardiac repair. Or you may see extracardiac repair because the lateral tunnels or the AP Fontans have been converted to an extracardiac repair as adults because their prior repairs had failed, and the feeling was, and many of them have done better with a converted Fontan into an extracardiac. We have done a few conversions here, not many. Most of the conversions have been done in Chicago. I know that's only scratching the surface of this, but I'd like to move on to what are all the effects of the Fontan physiology. It really isn't just heart disease at this point as they move into adulthood. That physiology causes a host of problems over time. And it's really more of a multi-organ disease. I have focused more on the cardiac effects in this talk. There is more to the story than this, but it's difficult to couch that all in one talk. Starting with the arrhythmias in the Fontan population, they are prone to arrhythmias. They have an increased risk of sudden death. Most of what you'll see are supraventricular tachycardias. You may see some ventricular tachycardia, some sinus node dysfunction, junctional rhythms. And so this is something to be aware of and have a heightened awareness of when you're taking care of these patients. Atrial pulmonary Fontans, 40% of them get sinus node dysfunction, and the lateral tunnel and the extracardiac Fontans tend to get less. It doesn't mean they don't get any, they still have higher risk for these rhythms. Atrial rhythms are very common in atrial pulmonary Fontan patients, and extra cardiac Fontans tend to have quite a bit less, but still a fairly high percentage get these at 12%. Heart failure. Understanding why these patients get heart failure is complicated. They don't get heart failure for the same reasons at all that other adult patients get heart failure. They have elevated central venous pressures. Why? Because, as we mentioned, there's this passive venous flow that's going directly to the pulmonary arteries. And the only way that flow moves forward is basically when the pulmonary artery pressures are lower than what's coming forward. So if they get pneumonias or they get asthma or pulmonary vascular resistance that raises for any reason, then forward flow doesn't happen as well, if at all. So that's a really good principle to keep in mind with these patients. They have chronically elevated venous pressure, so this puts pressure downstream on their liver. And so we're watching for liver disease in these patients, which I'll go into later. They get both systolic and diastolic failure. You know, if they start out with the right ventricle that's the main pump, you can imagine why that fails over time. It wasn't designed to do that. And the left ventricles fail because of all the other abnormal parts of that anatomy, which we'll go into here. We think that the cumulative effect of multiple cardiopulmonary bypass runs may play a role in that there were likely periods of myocardial ischemia that could have affected their heart. Many of them have been through at least 3 bypass runs before they're 15. So, and the ventricle is now having to work through 2 resistant beds, the venous and the arterial. And so this increases the chronic pressure and workload of the ventricle, and it simply fails over time. Other reasons for heart failure have to do with valve dysfunction. As the geometry of these ventricles, as they grow and they're not working as well, the geometry of the valve changes. Some of them were born with not very well working valves, and even if they only had a little bit of valve dysfunction initially, it worsens over time and leads to elevated atrial pressures and increased pulmonary vascular resistance. A typical thing we look for on an echo in a Fontan patient is how is their ventricle functioning? Is their Fontan circuit patent? And how does the AV valve work? So often there's really only one atrioventricular valve in there, and so that's the one that you're examining on an echo. There's usually one there's usually one systemic AV valve as well. There can be 2 AV valves that we're watching depending on the repair and what was done. So in terms of what you're listening for, you might hear a single S1, you might hear a single S2, or you might hear both. Obstructions in the flow is also problematic, causes ventricular hypertrophy and dysfunction. One example is subaortic stenosis. This is another thing that we're watching for in echo reports. Diastolic dysfunction occurs when all these pressures are rising in the heart. Specific obstruction in the Fontan circuit, this causes a whole host of problems, and this is a big reason why you'll see us easily move to doing a cardiac cath in these patients to see, is there an obstruction that we could perhaps relieve and restore some function. So if we see sluggish flow, then we think it could be obstructed. Other signs of obstruction are a dilated coronary sinus and the formation of collateral vessels, and these vessels sometimes lead to a little bit more cyanosis as well. And so if their sats are dropping, you might think, maybe there's an obstruction in here somewhere. So remembering that cardiac output is determined by pulmonary vascular resistance that the ventricle has to overcome, and what happens is it's overcoming a lot of pulmonary vascular resistance because it's passive flow, and this is part of why the heart fails over time. It just can't keep working against that. We think that increased pulmonary vascular resistance is due to the lack of pulsatile flow, and this leads to endothelial dysfunction, and you will see a fair number of our patients now on sildenafil trying to mitigate that increased pulmonary vascular resistance, and I believe it has shown them to improve in their functional status or at least stabilize them. Just a minute on elevated pulmonary vascular resistance. We've touched on the first topic already. You know, we also look, you know, depending on what the disease is, if it's pulmonary atresia, which suggests that there's something about the pulmonary artery or the valve that are not well formed or narrow or not there. If these lesions have been fixed or stented in the past, they can narrow down again or have obstruction to them, so it's important for us to, like in a cardiac cath, look at the pulmonary arteries and see, you know, is there a narrowing, is there, the stent is not open as well as it could be. Microemboli play a role. Elevated pulmonary lymphatic pressures, so with the elevated central venous pressures, you also get pressure on the lymphatic system as well. Liver failure is the other, which we touched on earlier. This is a pretty cross-the-board problem for all Fontans, APs, laterals, extracardiac Fontans, and we are screening a lot now for that by doing liver ultrasounds sometimes, most of the time more likely jumping to a bigger imaging study like a CT or an abdominal MRI, because these really show better what's going on. And we're looking for cirrhosis, we're looking for hepatocellular carcinoma has a higher incidence in this population, and we're looking for varices and other liver lesions. You also, because of the liver dysfunction, you're getting the dysfunction of some of the blood cells. You get thrombocytopenia, and typically you'll see maybe a little bit lower platelet count, but maybe all the rest of the numbers look fine. Or you might start to see an elevated bilirubin, but everything else looks fine. And this is just a sign that, you know, they've got this process going on, but it just hasn't become prominent yet. So these are some of the typical screening labs that we do. We screen for hepatitis A, B, and C. C in particular because they had surgeries often at a time when we weren't screening the bank blood for hep C. So, you know, if you can imagine having surgeries in the 90s or the 80s or before, you probably did pick up hep C in some instances. Fortunately, now we have a treatment for that, which is wonderful for our population. Protein-losing enteropathy is also one of the downstream effects of this repair. As I mentioned, this high central pressures also affect the lymphatic system, and this is thought to be a lymphatic derangement that occurs in about 3 to 15% of patients following Fontan repair. It presents as vague GI symptoms to ascites, pleural effusions, peripheral edema, severe gut edema with diarrhea. And basically it's a disease where protein leaks into the GI tract as a result of systemic venous hypertension, inflammation, lymphatic hypertension, increased mesenteric vascular resistance, leading to the loss of serum protein, which then manifests as edema, ascites, and decreased serum calcium. Can also cause immunodeficiencies because you're losing those immunoglobulins in with the protein. And there's people have postulated that serum proteins lost in the GI tract may contribute to thromboembolic events and infections. We have seen in some cases that high doses of spironolactone can help with ascites, but the mechanism is unclear. Just ascites in general for Fontan patients, not possibly in some who haven't been diagnosed with protein-losing enteropathy. This is sort of a schematic kind of depicting sort of the vicious cycle of Fontan hemodynamics. Mild cyanosis. So many of our Fontans are mildly cyanotic. They have their baseline sats can be not 90, not 92%, and that's because it depends on where their coronary sinus ended up when it was repaired, and many times if it's on in the left, if it drains into the left atrium, then you're going to have a little bit lower sats at rest. And then that means from there, if you're exerting yourself, you might drop even lower. If you didn't have baseline sats of not 90%, then, or even if you do, oxygen saturation less than 90 suggests a right to left shunt. And it might be due to collateral flow. So there's something about the way the flow bypasses the normal route and goes directly to the lungs that somehow can promote these veno-venal collaterals. Actually, that's actually more true before the Fontan repair, where this blood isn't really all going through the lungs. Once we get the Fontan repair, often the collaterals aren't as prominent. There's something in the liver a substance in the liver that we think likes to see the lungs, and so then prevents these collaterals from forming. But we do also see the collateral vessels form in the Fontan physiology because of that obstructive tendency that I described earlier. Converting to extracardiac Fontan actually helps with right atrial distension and decompressing the collateral flow of these that forms in the collateral vessels. So in answer to your earlier question, that's one reason that we do it. And we can coil embolize collateral vessels, and if they have a fenestration, which I mentioned earlier, that pop off into the right atrium, sometimes closing that can help. Other general things about these patients, they all have some degree of exercise intolerance. And so you can have a perfectly healthy looking Fontan patient, but they will be less exercise tolerant than their normal peer. This is sort of a declining thing for them as they get older. Their exercise tolerance gets worse. It's one of the arguments we use with insurance companies who see these patients as otherwise being normal and don't want to pay for echocardiograms. We can always cite the decreased exercise tolerance because that is a cardiac symptom. They can get chronotropic incompetence, and so they just can't get their heart rates up when they're exerting themselves, and that's part of why they have a poor exercise capacity. And we think that the abnormal pulmonary compliance is thought to play a role. We do often perform serial exercise testing, so might not be every single year, but once in a while we'll do it, and we definitely do it at baseline to sort of have a place to start from. So this is a slide, since those of you are working in the ICU and heart failure, you'll appreciate that the question is raised sometimes, well, why do we do the Fontan? How come we don't just transplant these patients? Because there is such a thing as newborn transplant now, and has been for a little while because of the ability to transplant patients that don't have a perfect match in the neonatal period. The outcomes for Fontan for single ventricle patients doesn't seem to be that much better if we transplant them. what we know about transplanting in Fontan patients is that in the first year they do more poorly than the other adult heart failure population. So they tend to die in the first year. If we can get them out from the first year, then they tend to do pretty well. It's that first year that's the hard part. And but you can see that the outcomes, transplant versus Fontan survival outcomes are not, are kind of equal. Like no one kind of rises to the surface as being a bit better option at this point. So you sort of are trading one set of problems for another. And like I said, they don't always do well in transplant, and they may not be good transplant candidates. And that's sort of a current discussion that's going on, like shouldn't we be transplanting these patients earlier? It's difficult to convince the powers that be that these patients need the heart before someone who's sitting in the ICU on a VAD. But they actually would do, we think that this diagram would change quite a bit if we were to transplant them early. Likely these studies were done on Fontan patients who had already had terrible liver failure, probably had some pulmonary vascular derangements, et cetera, multi-organ problems that were more or less irreversible. So just something to think about. So we don't really know how long the extracardiac Fontan patients will live. So when you think about talking to these patients, you're inevitably going to get questions about like, well, you know, what does the future hold? And it is a little difficult to say. I mean, we do know that Fontan patients have all these problems, but again, the oldest extracardiac Fontan patients we have that have grown up from neonates are in their 20s. And again, we do have some AP Fontans that have been converted. So these are two different types of Fontan conversions, and these patients aren't in large enough numbers that we have large studies like you're used to seeing in adult cardiology. They're smaller numbers, they're often multi-center studies, and they're more difficult to do. That said, I think that there are more and more results becoming available, and we continue to try to pursue scientific data to help us guide what to do with these patients. So they're looking at this, you know, when they transfer from children's to here, you know, they're looking at lifelong expensive testing, MRIs, CPETs, echoes, often some of them annually, and you really need good health insurance to pay for all that. So you can imagine there's a fair number who aren't really able to come in all the time, and therefore they're you know, showing up in the emergency room. So our challenge is how to keep these young people in care. So teen and young adult transition is a topic I wanted to touch on. Transition, when I say that word, means educating a patient on, you know, a young teenage person on how to take care of themselves, meaning how do they understand their diagnosis, for example. I mean, most of these kids are used to their parents doing everything and understanding everything, and they're not really having to. But as they approach adulthood, we don't want them to abruptly fall out into the adult world and not be able to articulate what it is they have. So for a number of years now, there have been transition programs in place across the country, but we're still working to try to keep these people in care because they've often gone through long periods of time where they feel fine and they aren't necessarily convinced that they need to come to the doctor. Or they don't have good health insurance. There are a host of reasons why they don't tend to come in. Earlier today, you all heard the talks about the cognitive delays that some of them have, and that plays a role in their ability to follow up and learn their disease. As you can imagine, it's hard for us to understand these diseases, much less explain them to someone who doesn't have a medical background. So we typically try to start talking about some of the transition topics, like health insurance, family planning, maybe not family planning at 14, but depending on the girl or the guy, you might start talking about it depending on how mature they are in terms of contraception. We do get, on the subject of pregnancy, we do get Fontans through pregnancy, especially the ones that aren't blue. So if their oxygen saturations are pretty good, their ability to get through pregnancy is better than someone who is cyanotic chronically. So we cover a host of topics along that, like you need, to have a good job in order to have good health insurance, and you need to avoid alcohol and drugs, and avoid tattoos and piercings if you can, or if you have to do it, how can we help you do that more safely? Pick a good provider that, autoclaves the needles and, things along those lines. And we know that only about 50% successfully transfer care to an adult facility once they're 18 to 21. So ideally we talk about these transition topics all throughout their visits, starting at age 12 to 14 and up through 18 to 21. And then ideally they're ready to transfer over here, and that they're already able to make their own appointments and take their medicines regularly and understand their heart disease. You can imagine there's a whole spectrum of those people. Some hit 21 and they're nowhere near ready, whereas others have been doing it since they were 15. So, we have a fair number that are lost to care. 50% when you look at most of the data in Canada, here, even the UK. This is just a slide illustrating this, a Canadian study that says that 50% fall out of care and didn't ever successfully transfer to the adult facility. So what happens? They show up in emergency rooms when they're very sick. Again, these are some of the issues we cover. I can't emphasize enough dental care. It's unfortunate that many people don't have access to dental care. We do refer our patients to the advanced dentistry here. That's typically the first stop for a lot of these folks if they just need a cleaning or some repairs on their teeth. And if they need any kind of anesthesias, they need a cardiac anesthesia. It needs to be done here. They're very complex patients, and undergoing anesthesia puts them at much higher risk. And so if you add on top of that it being done at an outside facility where the anesthesiologist either doesn't have a cardiac background or doesn't understand Fontan physiology, then they're at very high risk. So we always bring these patients back here for any kind of anesthesias, even GI surgeries or whatever it is, they end up here. And then in terms of family planning, I can't emphasize enough about how we really try to have the females on contraception. And it's something we bring up in our visits. It's something that should be explored whenever they have contact with the medical facility. Because these pregnancies need to be planned. We need to do that intervention for a Fontan obstruction before they get pregnant. As you can imagine, trying to do an intervention, forced to do it when they're already pregnant is not a good option. I just included this. I wanted to tell you about the Adult Congenital Heart Association. It is actually a layperson's organization formed by congenital heart patients, but it does have a professional arm, and it's kind of an interesting organization where it combines sort of patients and providers. They have a conference probably once every 3 or 4 years where they have a combined kind of professional section of the conference and a patient section, and they have a great website for patients and professionals. You'll find like a directory with all the HHD programs in there and how big the program is. I usually tell patients that it would be good to try to find the biggest program that you can, but definitely a congenital heart provider or someone who has some knowledge of what you have. You can like pull up many of these diagrams that I flashed by you today, and you want to look a little harder at those. I think it's more useful to do that when you actually are looking at a specific patient. You have one on the ICU right now, an and I won't name her name on film, but it's a Fontan patient who you could look up her diagrams or ask me or anyone on the team to explain that to you as a starting point for trying to understand what the Fontan physiology is. We also let patients know about the website. It's, you know, a lot of times these patients, they're rare enough that they often don't even know anyone else with their disease. And so it's nice to be able to connect them into this national resource when you can. Here's some other helpful websites. The American Heart Association now has a really good congenital heart website, the American College of Cardiology. In fact, the national guidelines for adult congenital heart disease care come from these two organizations, and there are a set, I think, from 2008, and they're currently being rewritten, and we will have some new guidelines out before too long. But that's a good place to look to for kind of getting an idea of what providers are thinking about in terms of the care plan and why. Canada, the UK have very well developed congenital heart associations, much like our adult congenital heart association that I described earlier, so I would recommend that you check those out if you ever have a patient and you're thinking you want to understand a little bit more about this. I'm going to end here and see if I could answer any questions. I know that was kind of a lot of information thrown at you, and don't feel bad if you feel like you didn't pick it all up. Questions? Yes?
Maybe this is a silly question, but like if you transplant a neonate, they're on those immunosuppression, does the heart grow like
Yes.
appropriately with as the child grows?
Yes, and you know, they don't, their immune systems aren't as well formed. I mean, this is my sort of limited understanding of, I'm not a transplant specialist, so, but their immune system isn't as well formed, so they don't reject things like adults do. And so, yes, their heart does grow, and they don't require as much of those immunosuppressive drugs. So, good question.
I don't know if you can answer this or not, but I'm super curious about the genetics. It's a chromosomal disorder.
No, you know, in fact, congenital heart defects, you know, if you're sort of in that general group of 1% of all live births, they haven't tagged one specific gene to general congenital heart disease, meaning anything from hypoplastic left heart to a ventricular septal defect, if we look at it on a complexity spectrum. There are some diseases, some congenital heart diseases, you're correct, they have tagged genetics to, like Marfan's, where you have a big aorta, and this is considered congenital heart disease, and that defect is passed down at a rate of 50%. What we do know genetically about the sort of general congenital heart disease is that, you know, someone who doesn't have another syndrome, for example, all they have is congenital heart disease, that's passed down to their offspring at a rate of about 3 to 5%. So it is higher than the general population, because the general population is 1%. That is someone who doesn't have congenital heart disease and is having a child. So it is passed down, but we haven't tagged specific genes to all this huge spectrum of congenital heart disease. And when I say the huge spectrum, next week I'm going to go into the DTGA, the LTGA, Ebstein's, tetralogy of Fallot. You know, there's a list a mile long of these things. It's a large group of diagnoses, and so many of those diagnoses too are not genetically tagged to anything. There are some of them where there will be coexisting genetic syndromes like DeGeorge syndrome and things like that. Like hypertrophic cardiomyopathy, for example, is passed down at a rate of 50%. So these families we send to genetic counseling because this is a really high rate that they're going to pass this on, and we know that. With congenital heart disease, we tell people there's a higher genetic risk, but it's a little bit higher. It's not huge, and so many people do, you know, we don't really do genetic counseling for that other than specifically send them to genetics. We we will tell them that in clinic, but, so your question is a good one, and it's not a very straightforward answer. Yeah. Anything else people are curious about?
What's the
Yes.
oldest patient you have with Fontan's?
I think we have someone in their 60s.
70.
We have a 70-year-old. Yeah.
Okay, so they can
Um,
live a long time.
Some do. And so this is why this whole, like, how do you tell patients how long they're going to live? Well, we're still kind of trying to figure that out. We are telling them that there are problems that are we're seeing and that we need to screen. But I think it's important not to take away hope when we don't have a good reason to do that. So we simply want to keep them in treatment. That's the way we think we keep them the healthiest.
Was that person like the exception though? Like,
Probably.
There's not many like
There are not
up
many,
there?
no.
Okay.
You're right. The 50 to 70-year-old is very rare.
Okay.
Can name a few others that are that age,
And I
but,
think it was a late diagnosis too, it wasn't.
right,
It wasn't severe, so there's all these different severities from,
right.
what's the other one, not tricuspid atresia, but Ebstein's. and
Ebstein's
things like that.
anomaly.
So all the single ventricles, there's different severities of that.
Mm-hmm.
I did wanna add one thing though, for the providers, we the nurses typically, when there is an inpatient, if the patient has had a cardiac cath from Tom Jones, we will, it's very detailed diagram that he prints out of the physiology of the heart. We print that and we bring it to the room and we'll tack it inside, so it's for the nurses, so we provide education for the nurses on the floors, and also for the providers, so that if you guys are caring for it, if you notice something tacked up on the board, and you see it's a full-blown, diagram, it's a very nice diagram, it actually helps to show that specific patient's, physiology of the heart, and then, it's very helpful for the providers as well. So look for those if you're taking care of those.
You get that out of Orca? Do you print it? Like, do you?
We pull it from Epic or
Epic.
Orca, yeah, we'll usually print it out when we know, we keep a list of all the inpatients, and when we know that the patients are, upstairs, then we print them and bring them up there. A lot of times the nurses will go, well, what's this? And we go, well, that's for you guys, just keep it inside so that we know that it's there.
Lisa makes a really good point, because even though I present these diagnoses as single diagnoses, we have plenty of patients that have multiple congenital heart diagnoses. So they'll have, coarctation, they'll have hypoplastic left heart syndrome. In fact, 40% of hypoplastic left heart syndrome patients have had a coarct before. And so there are a lot of combination lesions. And so you can assume that when you see LTGA, for example, which is otherwise known as congenitally corrected transmission of great arteries, if that's the only diagnosis you see, you've got to dig a little to see, is that really the only diagnosis? Because they've often have other problems, other congenital heart problems. So you might have an AV canal tetralogy of Fallot patient, so these blended lesions, and it gets more, and double outlet right ventricle, which is on the spectrum of tetralogy of Fallot, depending on, it gets very complicated. So I would not assume that when you see one little diagnosis blurb that that's really the whole picture. It gives you an idea, but really each one of these patients is very individual, and they have individual lesions that they were born with, and until you know what that is, you don't quite understand what that cath diagram is. But the cath diagram is nice because they typically list all the congenital heart diagnoses that they're looking at. And so, so for those of you who don't know who Dr. Thomas Jones is, he's the congenital heart interventionalist from Children's. He also works here now, works in both places. In fact, many people on our team, including myself, float back and forth from Children's to here. The nurses don't float, but the providers do. So we have an electrophysiologist who floats, congenital electrophysiologist who floats back and forth, interventionalists, and now we're hiring some newer ones. Brian Moray is a name that you'll hear. Zachary Steinberg is the fellow training into interventional congenital cardiology. We have now 2 congenital heart surgeons, Dr. Verrier and Dr. Josh Hermson. So it's a very specialized team, and So, you know, we like to know about these patients when they're here, and so feel free, we have adult congenital heart consult service, so either Dr. Krieger, Dr. Stout, or Dr. Dean are always on pager for the consult service. We don't ever primarily manage patients in the hospital typically, but so that's a little bit of overview of what our team is like now. It was much smaller even as soon as 2 or 3 years ago, but we've grown. And to give you an idea, we follow about roughly 3,000 outpatients a year in clinic. So that's patient visits. And so actual numbers might be 2 to 2,500 patients with 2 nurses, a nurse practitioner, 2 full-time FTE doctors, and 1 part-time. So it's a big load, and we're very busy, and that number is growing, and it's growing fast. So it's a fun place to be. Most of us on the team really like it, and we love to talk about it, so please ask if you want to. I think for some people here it's difficult. They find these patients a little bit difficult for the reasons that was discussed earlier in Dr. Williams' talk, that they are opinionated, they know what they want, they've been through the medical system over and over again, and they expect you to explain what you're doing and why you're doing it. They have specific ideas of where they want to be poked, and so, and you can imagine why. If this is your 5th heart surgery and you're 20 years old, you have a right to have some opinions, I think. So you'll get along much better with them if you also ask them who they want you to share medical information with. Often they are partnered up with their parent. Many of them welcome their parent into the picture to some degree. I'd say it's a minority of them that don't want them involved at all. But there often are certain topics they don't want you to share, and often about reproductive health. It might be the drugs topic, the obvious topics that none of us want to talk with our parents about. So that's a good thing to be aware of if they're younger and parent is in the room. And the parents appreciate you including them, because think about what all they did for this child up until this point. They really gave their heart and soul into getting these children into adulthood. And so they appreciate when providers include them when possible. Obviously, we always think about the legal requirement of only talking to the adult, but our service is very aware of that, including family, including support systems. Something that I think sometimes isn't as well done in the adult setting because of HIPAA and this fear of sharing too much information with everyone. There are ways to keep people involved. So thank you for your time, and we'll continue on next week.